Thank you, sir, for the introduction, and I thank Dr. Laskar, Dr. Absi, Dr. Hamad Qari, Dr. Saad Jaouni, all my friends for inviting me, and I'm happy to have a talk in between Dr. Oid and Dr. Tarawa, and I hope I will be of value. I'm going to present difficult bleeding consultations in our hospital, a single center experience. I'm not the head of bleeding disorders in our facility, but Dr. Mohammed Talat is, and we serve a 5,000 bed hospital, and so we have many hematology consultations. Many of them are bleeding disorders, and we serve adult hematology only. Let me share with you some of my cases, and I hope your input would be, because this might not be the right answer to any of these cases. So number one case is a 34-year-old hemophilia B Yemeni female and end-stage renal failure on dialysis, and she is fit for a kidney transplant. And the donor is her 36-year-old sister who still has hemophilia B. So they are both mild hemophilia B cases with an activity of 30%, and they are both on on-demand plasma transfusion, nothing else, and they were in Egypt for a while just for the kidney transplant. So we were really worried, not about the recipient but also about the donor, because the complications in the donor will be grave, and she is donating her kidney. There's nothing wrong with her, actually. We were also worried about recombinant factor 9 in these two patients, because they were having major surgeries, and so thrombosis could be there. But also, there is no real evidence regarding the use of recombinant factor 9 with dialysis patients. And a monitoring of factor 9 activity should always be done, and it should be done very, very closely. Now, what happened is just we looked at publications, and even hemophilia EA, only 9 hemophilia A patients were reported on peritoneal dialysis successfully receiving factor 8. Regarding factor 9 deficiency, one case was followed up by PK evaluation, pharmacokinetics of the recombinant factor 9, and it showed an improved half-life. And so it was really a challenge. So what happened, we looked at, this was a major surgery. We maintained the factor 9 level between around 50 international units per deciliter. We wanted an activity of around 50%, and both received factor 9. Now, I was worried about the donor mainly, so we did an ultrasound post-operatively, and there was only a mild post-operative pelvic collection. During surgery, it was uneventful. Nothing happened. She did not need any blood transfusion. Regarding the recipient, of course, was end-stage renal failure. She already had anemia. She was on ESAs, and she was receiving many medications. She received 3 units of blood, and her post-operative hemoglobin was 7.7 grams per deciliter. There was still mild intraperitoneal bleed, but not that much. So the patients were kept on recombinant factor 9 for 5 days post-operatively. We were following up the factor 9 level and activity very, very closely, but it passed. No major complication was noted, and 6 months later the patient came and said hello. Her creatinine was 1.5 milligram per deciliter. She was off dialysis. Hemoglobin was 10.5 grams per deciliter with no ESAs. So this was a success, but it was barely a success. It was a real challenge. Case number 2 is referred through rheumatology. That was a 38-year-old female, and she presented to them by bilateral knee pains, malar rash, and hair loss, and this rash. Of course, this was bruising, and she also had menorrhagia. So regarding rheumatology, her ANA was positive, DNA was positive, and it was positive homogeneous DNA, so probably this was a case of lupus erythematosus. The rheumatoid factor was negative. And regarding us, the hemoglobin was 10 grams per deciliter. Platelets were a little low. They were 100,000, but not that low to give this problem. PT was normal, but the PTT was prolonged, and there was no rectification on mixing studies. So we had a prolonged PTT, and so lupus anticoagulant, beta-glycoprotein, anticardial lipin, they were triple positive. So this was a triple positive antiphospholipid syndrome. But the platelets were not that low to give these bruises. So I should worry about clotting rather than bleeding. But the factor VIII level was less than 1%, and the inhibitor level was high. And so she had acquired hemophilia. So now we have an antiphospholipid syndrome, which can cause clotting, and on the other hand, we have acquired hemophilia, which is causing bleeding, and what to do. Do I give her a factor VIII with a high dose? What if she clots? So we looked at the acquired hemophilia management. If the factor VIII level is less than 1%, you consider factor VIII transfusion, and you consider rituximab together with corticosteroids. But if the inhibitor level is more than 30 Bethesda units, you consider adding cyclophosphamide. Of course, there are others that can help also the lupus and help the antiphospholipid, such as plasma exchange or immune adsorption. So what did we do? I did not give her any factor VIII at all. The patient received rituximab together with corticosteroids, 4 doses of rituximab 1 week apart, with better bleeding. Then the corticosteroids were weaned. Of course, the PTT still was high, 80 seconds, and I don't think it's going to go lower, probably because of the antiphospholipid, but still because of the acquired hemophilia. And the patient is still having minor bruises with some menorrhagia. Now we are following her up for the past 1 year. She still comes with bruises, but not as much as before. And she still has menorrhagia, but it is acceptable menorrhagia. My problem is the patient is still on maintenance rituximab. Once I stop the rituximab for months, she starts to bleed again. And so I'm keeping her on maintenance rituximab every 2 to 3 months. I don't know if this is right or wrong. I don't think this is, no one has the answer. But we are following up the patient. Last time she came was only 3 weeks ago. She's doing fine. She showed me some bruises on her thighs, but that is all. Hemoglobin is normal. She's living a normal life. Actually, she thinks of getting pregnant again. So this is the third case, and this was referred through neurology. That was back in 2021, and I'll show you why. She's an 82-year-old female. She presented by dizziness and right-sided weakness, and this bleeding tendency, as you can see, purpuric eruptions. And she did a CT, which showed a brain infarct. Her hemoglobin was 9.9, monocytic. Total leukocytic count was almost normal. Platelets were low, 25,000. And there was a high D-dimer. Corrected reticulocytic count was not that high. We thought maybe this would be a TTP, but the bilirubin LDH were normal. No fragmented RBCs, normal Adams T13 level. So first we thought of thrombotic thrombocytopenic purpura, but probably this was not the case. So we went back and asked her relatives, and she had an Astra-COVID vaccine 1 month before. And the platelet factor 4 heparin complex antibody turned out to be positive. So probably this was a vaccine-induced thrombotic thrombocytopenia. And actually, we looked at VITT management, no platelet transfusion, no heparin, and you should give IVIG 1 gram per kg for at least 2 days, which we did. So what happened? The patient responded, the neurological complications went away, platelets went up to 100,000, and then later on reached 160,000. But if you stop the IVIG, the patient relapses with more thrombocytopenia and more bleeding. And now we are following her up to this moment, and she is needing IVIG every 2 months. Up to last month, she was receiving IVIG. I tried to separate, to make the IVIG less frequent, every 3 months, every 4 months. She relapses, the platelet count goes down. I wait until it is around 50,000, or if there is bleeding, and then I give the IVIG. She needs IVIG now every 3 months. Is this only VITT? Is this only vaccine-induced thrombocytopenia, or was the patient having ITP and then there was an association with the vaccine? I don't know. But up to this moment, now she is 85 and she is still receiving IVIG intermittently. So this is another question. Case 4 is an orthopedics case. Actually, we referred it to orthopedics. He is a 40-year-old hemophilia A with a factor VIII level of 3%, no inhibitors, because up to the age of 40, he is only receiving plasma and anti-hemophilic globulin, nothing else. And because we are a referral center, he was referred to us from another city, not in Cairo. And he has been having this problem for 3 years. Recurrent hip and thigh bleeding, and recurrent infections in the organized hematoma for the past 3 years, and fever, and antibiotics, and then back. And no one wanted to touch him. Why? Because the thigh grew so big, and a huge pseudotumor was there. And the patient is obese. He's 150 kilograms. He came on a wheelchair. And he was miserable for the past 3 years. So we decided we had to do something. So what we did was we had a combined orthopedic surgery team. And it was decided that there was nothing else, no amputation even. Total hip disarticulation was decided. And this is the thigh after removal. So this very poor person, we had to remove the whole thing from the hip downwards. So this was a bloody operation. So what did we do? We decided to use the extended half-life factor 8. And with the use of extended half-life factor 8, we used the 80 international unit per kg for the first 3 days dose. And then we reduced them to 50 international units per kg. And the patient fared well. The bleeding on table was not that much. He did not need much blood. And then afterwards, there was some bleeding, but not that bad. And the patient fared well. Of course, he went back on a wheelchair, but at least he did not have the infections and the fever. And actually, he came 1 year later for another surgery, not in his limb, but in his elbow. Evidence for the use of extended half-life factor 8 is not that extensive. There was one trial using extended half-life in 45 major surgeries and 90 minor surgeries. And they reported that the patient needed 1 or less injection per day with a median dose of 81 international units per kg on day of surgery. And this is exactly what we saw. The patient did not need much blood, was not bleeding that much on the extended half-life. So probably we will be looking at the use of extended half-life with surgeries in this context. This is my last case. Do I have time? Okay. So this is my last case. It was a neurosurgery consultation. He is a 43-year-old male. He presented to them by sudden vomiting and unilateral numbness, followed by disturbed consciousness level. He's a known hemophilia A, and the patient is on prophylactic recombinant factor 8. With some bleeding, elbow bleeding every 3 months, things like that, but never cerebral. And we looked into the inhibitor level, and it was 8 Bethesda units. So probably with the repeated use of prophylactic recombinant factor 8, he went into an inhibitor status. And looking at the CT brain, they found a cerebral hemorrhage for urgent surgical intervention. And at that point, they looked at us and we need to do something. So what we did is we went into recombinant factor 7, and he received 90 micrograms per kg every 3 hours. And he was operated upon, and he went out with a drain. And we were worried about the amount of hemorrhage inside the drain. And we were more worried about repeated hemorrhage inside. But thankfully nothing happened. The drain was around 100 milliliters a day and then 50 milliliters a day, and then in 1 week the drain was removed completely. The patient regained consciousness. He still has numbness on one side. Now he is discharged. And the problem now is what further treatment? This is cerebral hemorrhage. And I'm really worried. This is not a joint with recurrent joint bleed. This is cerebral hemorrhage. This is really serious, and the patient has to be tackled in a different way rather than prophylactic factor VIII. So do I go for immune tolerance induction? This is an 80-kilogram male. He will be needing lots and lots of factor VIII. Do I go for prophylactic PCC or prophylactic fiber? Maybe 2 to 3 times a week, maybe prophylactic recombinant factor VII. Is this really practical? Because the patient is working, he has to go to work, he has to earn a living, he's 43 years old. Or do I consider imicizumab? And there are some studies considering imicizumab as prophylactic treatment in this setting. So in Egypt, imicizumab is only used in children below the age of 18. It is not used above 18 as sponsors, for sponsorship. And so I don't know if the patient is going to be sponsored or not, but definitely I'm going to go for imicizumab if possible. And I think you will advise me the same. My conclusions are a multidisciplinary approach. I think this is the best thing to do. And real-world evidence is always needed for extraordinary situations, because not only trials can give you the good result or the good answer. With that, I thank you.